Part 2. How folate helps treat these metabolic psychiatric symptoms. Folate is not a magic psychiatric pill, but in some genetic metabolic brain disorders, or GMBS, it really can be one of the keys to treating the root problem. In conditions like FOLR1-related cerebral folate transport deficiency, FOLR1 CFTD, CBS deficiency, cblCDisease, and MTHFR deficiency, folate-based therapy may help relieve psychiatric symptoms, either directly or as supportive treatment. Most people know folate as a prenatal vitamin, but in metabolic disorders, the folate family, folic acid, 5-MTHF, and folinic acid, leucovorin, isn't just a supplement. It can act more like a tool to help restore a disrupted metabolic pathway. In other words, you're not simply taking a vitamin. You're trying to restart a stalled biochemical cycle. That's why folate therapy is not one size fits all. Different disorders require different forms of folate, and using the wrong form may be ineffective, or in some situations may carry risk. So, what are the main forms we're talking about? There are three that come up most often: folic acid, 5-MTHF, 5-methyltetrahydrofolate, and folinic acid, also known as leucovorin. They don't work the same way, and their roles vary depending on the disorder. Folic acid. Folic acid is the most common oxidized form found in supplements. But once it's in the body, it needs multiple processing steps before it can become the active form, 5-MTHF. 5-MTHF is the active form that directly supports methylation reactions. These reactions are important for brain function, especially neurodevelopment and myelin maintenance. Folinic acid, or leucovorin, can act like a backup source in some situations. When transport or processing is limited, it may help feed into the active folate pool more easily. But it also has limits, especially when MTHFR function is reduced, because folinic acid may not fully replace what 5-MTHF does. Choosing the right form for the right metabolic problem. Different metabolic problems call for different folate forms. For FOLR1 CFTD, the issue is basically that the entry route into the brain isn't working well. Folate can't reach the brain effectively.